presentations on COVID-19. I'm Hala Ali, the coordinator for Easter Alliance for Global Health Partnerships and Easter Island, and this is our 7th webinar of the series. These webinars take place on Fridays at 1 p.m. Irish time, and every week we host global health experts to discuss various topics related to COVID-19. A recording of this webinar and the previous webinars will be available in our website, the one shown on the screen, and also on our YouTube channel. Live streaming is also available right now on our YouTube channel, Irish Global Health Network. Today, we will discuss the gender dimensions of COVID-19 pandemic, and this webinar is co-organized with Women in Global Health. So, big thank you for Women in Global Health for their great efforts to organize this event. If you have any questions during the webinar, please use the question and answer feature in the bottom of the screen, and we will try to answer them all during the webinar. For now, I will leave you with my co-host Nadine Ferris-France, the Executive Director of Irish Global Health Network and Easter Island. Nadine?
Wonderful. Thanks, Hala, and welcome everybody. Really excited for today to have some friends here with us and some wonderful, wonderful women, all women and men. Thank you, Rory, joining us here today. We have Chitra Nagarajan from Nigeria. She is a journalist and a writer and an activist. She's involved in feminist and anti-racist and anti-fundamental and queer movements. So really looking forward to speaking to Chitra. We have Sarah, very welcome, Sarah Hillware. She's the Deputy Director at Women in Global Health. Great to have you with us, Sarah. We have Sasanki Misanai, no stranger to Ireland. She was with us a few years ago giving a keynote address. She's, as you all know, from South Africa, but at the moment in Australia. And she is many things, but also a writer whose work is focused on race and gender and democracy. We have the wonderful Sophie Dilmitris, the global coordinator of the Women for Global Fund network, and she's based in Zimbabwe. And we have Claire, who's joining us again, Claire Hayes, consultant clinical psychologist, who's going to give us just a little hit of mental health at the end. We decided it's really important for to have mental health no matter what we're talking about. So we're looking forward to that. And as always, we have Rory Brua, the former head of the Department of Public Health and Epidemiology at RCSI. So Rory, if we can ask you just to kick us off, and we're looking forward just to hearing where we're at, what's the context, and a little bit, if you can, about the differences between men and women in terms of what you're seeing. So thanks for that, Rory. Rory, you're muted at the moment. You need to unmute.
Okay, can you hear me now? Can you hear me?
Mm-hmm.
Yeah, great. So this week, I don't want to sort of blind you with data or figures, but maybe just get across some key messages. Well, what I put on the first slide here, you'll be familiar if you've been on previous webinars that we used to look actually at the WHO situation dashboard, and I put up 2 other dashboards up there, but we're not going to go into them because I think it just takes too long to get into the links. The John Hopkins one, many of you may be familiar with. So it's just to say, as a resource, it is good in terms of maps and trends, but it focuses just on 10 large countries, and it's good in the way it just displays the case data and the cumulative data. The second link there is to the Worldometer coronavirus dashboard, and I thought I really liked it until I found that it wasn't really giving me the new cases. But what it does do usefully is it gives you the numbers of tests that are done in each country, which I think is important for interpreting the case data that we see. Data is really problematic in the COVID-19 pandemic, and in Europe, no 2 countries are actually collecting and reporting data in the same way. And as I said, we'll just skip over the WHO dashboard, and we'll go to the next slide and look at this. This is a slide now that's pretty familiar to you. I've kept the same countries from last week, and it demonstrates that the Italian epidemic is quite mature and it's on the way down. USA and UK are still on the way up. It looks like the the growth rate in the last week has been, if anything, faster in terms of numbers of cases and numbers of deaths. China, as we said before at the top there, the only cases that they are now reporting are imported cases from Chinese nationals returning. Ireland, and I'm going to say a little bit more about it in the next one or two slides, it is much less favourable than people think. And that's what I've been reporting when I've been interviewed around it. And the upward trend is actually quite similar to the UK. And you can just see that comparing, from 17 to 24 to 1st of May, both for cases and deaths. I think there's been a certain sense of complacency that we were thinking we were doing things well. And I think compared with the UK, we have been. But we'll see in a minute some of the data that suggests we're actually not doing as well as some of us might think. South Africa, the one sub-Saharan African country that's probably got a reasonably good testing capacity, and you can see now that it's definitely at upward trend. It's more of an exponential than a linear upward trend in cases. Indonesia, we just discussed last week, and again the trend, it's an accelerating epidemic there. And Malawi, just being typical of those sub-Saharan African countries that aren't reporting. But as we said last week, actually, there does seem to be quite a delay in the epidemic reaching low resource settings. Next slide, please, Ellen. So I've just kept those two key points from last week. I'm not going to go drill down into some of these countries. It does seem that the world, to my mind, is divided up into the high, middle, and the low income, corresponding with the pace of the arrival of the epidemic across these three sort of resource categories. And what I put in there is it's a link to a document which I find quite interesting. I'm not going to go into the details, but it's on the East African community and their countermeasures against the COVID-19 pandemic. And I found it within the IHP. It's this Antwerp newsletter, which is very good on global health. And it's just, you'll see it if you go into that link. I think it's on page 2 to 4. What I'm giving a bit of attention to now, because I discovered this link within the Solidarity in Turbulent Times link, and it's to an article in an online resource called 2014-18, and it's referring to the Second World War. And it's the first time I've seen something actually describing the what's called the Spanish flu pandemic as it hit Africa. And there's a lot of lessons to be learned, and I'm seeing other lessons being learned in the US. So in the introduction, it just points out how many people died, 2% of Africa's population within 6 months. It's a very good article. I really would recommend it. I haven't had time to more than scan it myself. But if we go to the next slide, we see the conclusion. And I just will stop, and hope you can all read it there. I'll just give you a chance to read it. And you can see there the memory. It's rather like in Ireland, our memory of the famine that actually has got passed down through generations. And I was just computing, well, if 2% of today's population of Africa was to die, that would be over 26 million people. Now, I'm not predicting that, and I think I'm a bit of a Cassandra in that I fear a very bad outcome in Africa, because I don't think we have responses in place, and I think the contexts are so difficult. That the latter half of 2020 could be a very bad time, and I do think we need to be thinking about how to predict what's going to happen and how to mobilize attention to it. And at the moment, it is very difficult to mobilize the attention of the high income parts of the world to what may be coming down the road. But if we just turn to the next slide. So just current issues in Ireland, which I cover every week, because that's a lot of my time is actually taken up now on that. And this was something I was on prime time last night on being asked about the relaxation of the closures and stay-at-home measures. And for those of you in Ireland or who have family in Ireland, this is, I think, a reasonably good prediction. I think the only relaxation that we will see on the 5th of May, and it may be announced over the weekend, my guess is allowing elderly people out for some exercise. But this is some of the incidence of new community infections per day up until the 22nd of April was 3 times the European average. And during that 14-day incidence. And during that 14-day period, we were one of only 3 out of 30 European countries where the incidence was still on an upward trend. The other 2 features which have been particularly bad about the pandemic in Ireland has been the rate of infection among health workers is actually on the increase, which it's now up to 28% of all cases of infection. And I think, you know, we are coping, but I think it's another harbinger of what Africa and other low resource settings could be facing. And then, as anybody who's been following the news will be aware of, up to 60% of all deaths in Ireland from COVID-19 are from nursing home and residential institution residents, which has been our big failure. So next slide. So this is the one, this was a bit of a rush. I thought I had more time this morning, but I know that there's a great panel of speakers there who will speak to these issues with much more knowledge and experience than I can. Those first 2 points I think are well recognized now, and I just threw down some possible reasons why women, a higher proportion, contract COVID-19 compared with men. 58% of cases in Ireland, and may well be a good bit higher in low resource settings where there's much more reliance on women to as carers and to go out of the home and to expose themselves to the risks of being infected because they are the primary carers of the family. In Ireland, a lot of it can be put down to both health workers and carers in institutions, in nursing homes. I haven't really looked further into why is it that more men die. It proportionately, actually, in Ireland is closer to 50-50, but in some of the studies is up to 70% of deaths are in men. And they were some of the factors that were cited back in March. I know some of your speakers now will speak much more to these other issues of violence, which is both domestic and outside of the home. And I just, just quickly found just those reports just to identify some of the other issues, the unplanned pregnancies, as well as the gender-based violence. And Nicola just pointed out to me the potential for a surge in cases of child marriage, which was something I hadn't thought of. Next slide, Ellen. So thank you to Nicola just for these resources. Many of you will have them already, but it seems we put our presentations up online and they may be useful resources. And I think our last 2 slides are the perennial ones that I always keep in there until we really get a handle on what it is we should be doing in low resource settings. And then the final slide, Ellen. So that's it, Nadine and Hala.
Thank you for that, Rory. Thanks for bringing us up to date. Always lots of food for thought. So I'm going to move straight into our panelists so that we can pick up on these themes around gender. I think we're all very interested. We're very aware that there are a lot of implications, both for women and men, different implications. So I'd love to come over to you, Chitra, if I may. I'll start there. We come over to you in Nigeria, and we'd really love to hear from you in terms of what is the situation at the moment in Nigeria in relation to COVID? And do you have any kind of immediate concerns or insights about the different impacts that gender, that COVID is going to have on men and women?
Thank you very much, and hello everybody. So in Nigeria, the extent of what is happening when it comes to COVID-19 is currently unclear. There have been rising cases, but in the absence of widespread testing, it's difficult to know what's happening and where it's happening. There are lots of rumors going around of particular places where people report seeing increased numbers of people dying. Whether that's COVID-19 related, we don't know yet. And when it comes to gender, as in other countries, this pandemic really overlays pre-existing inequalities. And so what we're seeing is not really new, but that some of the issues of access, rights, and inequalities that we saw before the pandemic have really been exacerbated. And so together with feminists in Nigeria, I was part of drafting a policy statement outlining some of the potential gender implications of the pandemic in Nigeria, and our concerns fall into 5 main categories. So the first is around healthcare systems and access to health. Second, around economic impacts, including care work. The third, gender-based violence. The fourth, other human rights violations. And the fifth is the absence of women and gender analysis from leadership and response. So in terms of healthcare, we know that in Nigeria already, women had issues of accessing healthcare because of financial reasons, but also in some parts of the country because of social norms, because there were very low numbers of women health workers, particularly in rural parts of northern Nigeria, and men would not allow their wives to see male health workers. So women had very low levels of access to healthcare even before the pandemic. And what does that mean in terms of prospects for diagnosis and treatment for COVID-19 related illnesses? Also, what we're already seeing is that COVID-19, because the focus is on COVID-19, yes, that means that healthcare is not available for other things that people need. Illness has not stopped. Healthcare needs, sexual and reproductive health needs have not stopped because of that. And I can use family planning as an example of this. So every quarter, the Minister for Health, the Federal Minister for Health, approves the release of distribution of family planning materials across the country. As I speak, the distribution for this quarter, which started a few weeks ago, has still not happened because that approval has not come through. And we are hearing, particularly in states with high family planning needs, that stocks are empty. So women are not getting family planning materials. Also, potential implications on unsafe abortions, we don't know, but Nigeria already has highly restrictive laws when it comes to abortion. And we know that in times of crisis, that rates of unsafe abortion increase, especially when women and girls do not have access to contraception. So that's on healthcare. When it comes to economic impacts, as in other parts of the world, women are more likely to be in the informal sector, be financially precarious, and obviously the movement restrictions have affected that. There's also been some early indications of men divorcing their wives because they're not able to fulfill, the traditional masculine role of the breadwinner. So just yesterday, I heard of a person who's internally displaced in Northeast Nigeria, divorcing his wife, who actually has just given birth to their first child because of this. And also, obviously, implications for women's care work, as we're seeing in other parts of the world, both when it comes to increased household tasks, care of children who are not in school, but also things like provision of clean water, which the government says is needed for protecting you from COVID-19. And the burden of that falls on women and girls. But also, this government guidance does not meet people's realities. People do not have access to safe water. And there's a lot of anger and frustration actually around this. And that raises the question of COVID responses that are developed in other parts of the world, where the system, the welfare system, access to healthcare, the economic system is very different, just being not adapted for contexts such as Nigeria. Violence against women and girls, we don't have any clear data yet that looks nationally, but we do know that the Lagos State Sexual and Domestic Violence Response Team, within 36 hours of movement restrictions in Lagos, announced that they'd seen an increase in calls already. And they later on said that the number of calls had increased 50%. Yet services struggle to function, particularly given that gender-based violence services have not been classed as priority services by the government. And so in every state across the country, we're hearing of people working for GBV services, even struggling to get the passes that they need to be exempt from movement restrictions. So even if women are able to call, and we know that a lot of women are not able to call, what support is available for them? Because not only are the numbers of cases increasing, but there's some early indications also that the levels of violence are increasing. And here I'm not just...
What would you say? I mean, you've described, I mean, so thoroughly the context, you know, particularly for women. I mean, what would you say? Do you have any recommendations for what a gendered response to COVID could look like? You know, and I realize that, you know, we don't even know all of the information yet, but based on what we know from other situations, what would you say? You know, would you have, say, 3 recommendations that you would say, okay, we must do this for a good gendered response?
Yeah. I mean, overarchingly, I think that the government really needs to take gender seriously, and they're not taking gender seriously at the moment. Yeah. And I think we need more women on the presidential task force that has been set up, plus state committees that have been set up to respond to COVID-19. We need a clear strategy around violence against women and girls when it comes to response, but also when it comes to prevention. And we need like a gendered economic analysis of economic impacts, and for that to be reflected in government mitigation measures, including through the recognition of women's unpaid care work.
Right. Wow, thank you, Chitra. Thank you so much. I'm going to leave it there for now and circle back around to you, and maybe just head over to Sasanki. And just to say, Sasanki, you know, what do you know, in terms of South Africa, what are you thinking that the response COVID is having? What is the impact COVID is having on men and women in South Africa? And I know a lot of it will be similar to what we've heard from Chitra, but it'd be great to hear from you. Yeah.
Sure. Hi, everyone. Thanks, Chitra. That was really great. Very helpful in framing the issues. So I think the first thing to say from the beginning is that obviously COVID is a feminist issue. This is a question of power. And as we always see in times of crisis, women are the hardest hit, even if there may be some evidence physiologically that they won't necessarily be the highest hit biologically. We know that women tend to be the hardest hit in terms of the social impacts and the social indicators. So clearly, this is a question that women should be concerned with, but that I think feminists in general should be concerned with. I want to talk a little bit about the state of the epidemic in South Africa, and then I'll talk about the nature of the lockdown, and then I will talk about how people are thinking about what happens on the other side of this the most immediate crisis. So I think everyone saw the statistics. In the beginning, South Africa has an epidemic that is clearly beginning to take shape in the Western Cape province. And so there we have about 2/3 of the national figures for COVID infection are in the Western Cape. The Western Cape, for those who are unfamiliar with South Africa, is the richest province in the country, and is also the province in the country that's probably in some ways most globally connected. You could say the same for Johannesburg, but in some ways the same is the case for Cape Town. So I think that's where we see the infection has come from. South Africa, as you all know, is incredibly racially segregated, continues to be that way. And so what we're seeing with the pathway of the infection is that it began as an epidemic that came because of travelers who tend to have access to people who work in their homes. And I think the real worry for people is what begins to happen once poorer South Africans begin to get infected. We've begun to see that happen, but we're nowhere near, I think, the real difficulty with the crisis. So at the moment, as with many places in the world, the question is not about the number of cases. In South Africa, it still looks relatively low. The issue is about underdetection. This week, if you look at the media, not just in South Africa, but around the world, you will see, and this for me, that has been fascinating to watch how journalists have covered this question. There hasn't been enough reporting on the gender dynamics of HIV. I'm a writer, so I'm always looking and thinking about how people are talking about this question. What is the narratives? And we see that there hasn't been enough gender analysis in terms of media reporting about this, but still in terms of general reportage, we can see that there is this gap between true cases and detected cases. And what journalists are beginning to do is to look at death registries. And if you compare death registries at this time last year to this time now, that's where you see the gap is giving us a clearer sense of what the true picture is in terms of the impact of COVID in terms of mortality. So it's been interesting and obviously very sad to watch as people try to get their head around such a fast-moving pandemic and how to talk about it and how to think about the impact it's having in the absence, obviously, of really good figures. In a country like South Africa and many of our countries that are poor, we simply do not have the data, as Chitra has mentioned, to really be able to back up what we think we know. Our hunches are strong. We work in communities. We know what's going on, but we don't have the data to be able to provide some of the evidence. Clearly, I think, as we know, women are the key caregivers, and women are going to be tasked with picking up the pieces, with caring for people, et cetera, and that's going to have a significant consequence. In terms of the nature, I want to talk a little bit about the nature of the lockdown. I am very lucky, although sad, that I'm living in Australia, because we were due to be in South Africa right now, and due to the travel bans and restrictions, I cannot be at home with my family, which has been very difficult. My father has been in hospital, and there was a COVID outbreak at the hospital, at the institution he was staying at. And that was really frightening, not having information, not being able to go to be an advocate for him at that time. One of his doctors had to go into self-isolation. So it's difficult. The nature of the lockdown in South Africa has been characterized by this very strange paradox. On the one hand, a very firm and strong response. I think a lot of people have commended South Africa for its response. On the other hand, as the weeks go on and people need to have more information and more justification for why decisions are being made, I think it is really testing for many of us in Africa. It is testing that connection between our citizens and their leaders. And it speaks directly to questions of democracy and accountability. So if decisions will continue to be made on our behalf because there's a public health threat, I think it is incumbent upon leaders to explain precisely what the data is around which they're making their decisions. And I think everyone understands they may get it wrong, but I think there are real questions that have begun to be raised this week with conflicting messages and so on and so forth. But the consequences of the nature of the lockdown in South Africa have been quite significant for women, as in many other parts of the world, and as we've already discussed. So gender-based violence is a real concern. We've had a number of the nonprofit organizations that I've worked with for many years are reporting increased numbers of calls, women trying to reach out. Being locked down in a home, if you are lucky to even have a home, is the worst situation for someone who is dealing not just with the direct violence, but with all of the things that lead to violence, which is coercive control, right? So we know that the serial and compulsive checking by male partners on women, what they're doing, what they're doing on their phones, who they may be speaking to. All of that is exacerbated in an environment of proximity. And so it's not simply, and I'm glad there'll be someone talking about mental health, it's not simply the question of direct violence and abuse, which we know is going to explode and is already happening, but it's also the question of coercive control. So that continues to be a very large problem. And then I think, and I could repeat what Chitra has said, but I think same dimensions. We know what's happening with women. I think the real question is what this will mean on the other side of this epidemic. And this is a question for all of us who are living through this moment. It is totally unprecedented that we've all, no matter where you are in the world, you are going through the same thing at the same time. And it is also the case that wherever we are in the world, we are always going through the same exact experience of being human. So I think this is a moment to really think about what solidarity looks like and means, and why it is that only in moments of crisis do we see ourselves as going through the same thing at the same time. Why is it that until now we haven't been able to define ourselves as experiencing the same emotions? What it means existentially to be human is always the same. But of course, there's this added sort of urgency and intensity to this moment. So what that means, I think, obviously we've seen this week a real break, in terms of political analysis, I would say. On the one hand, you have people who are urging us to rush forward into the future so that we can pick up at the accelerated pace of globalization, of climate destruction that we were doing before this. And then there are those of us who are saying, hang on, this is a moment to pause and to think about what it means to live in a world where you can afford to give people just income, where the state has a role to play in helping people when they need support, where we don't have to fly every single day and destroy the planet, where civets are now walking in the streets of Delhi because they never were able to before. So I think it raises some real questions and real opportunities for those of us who have been waging a whole bunch of other social justice and environmental justice questions about what normal looks like, and trying to stem the tide of what normal can look like as we try to move into a better future.
Wow, Sasanki, thank you for, as always, just provoking so many thoughts, so many pieces going off in my brain at the moment. And I would really love just to ask you just one question before I move across, and that is just about men, because I think it's really important that we know how important it is that we focus on women, and to hear all of those issues just, outlined by yourself and by Chitra. But can you just say something about what do you think the effect of this is already having on men, or will have on men longer term? Just briefly, if you can.
Sure. I'm not sure. To be honest, that's not a question that I think I know exactly the answer to. In the best case scenario, I think and I'll answer it existentially rather than scientifically. I'll answer it from my writer's brain rather than anything else. I will say that the experience of being vulnerable is humbling. And that what we are trying to do so often in these conversations that we have about men and about masculinity is trying to help men to think about accepting help, acknowledging that they need help. And often there's nothing like a physical ailment to make you understand and appreciate what that means. Turning that into a larger structural ability to have empathy and to exercise less power, I think, is a different question. But I think it does provide, once again, an opportunity for a feminist moment in which women are able to help men to make the connections about what this means in their personal lives and how that relates to the broader things and ways that they may be able to operate in the wider world.
Mm-hmm. Thank you, Sasanki. Wonderful words. Thanks a million for that. Okay, I'm going to move over to Sophie. Sophie, you're in Zimbabwe, so we're really getting a spread across the different countries here. Sophie, you're leading at the moment. You're a global coordinator for Women for Global Health, and we've had Women for Global, the Global Fund. Now we've had the Global Fund on with us twice in our webinars, so we're really keeping track of what's happening in the Global Fund. What are you seeing in terms of gender? What are the things that you guys are really thinking about and engaging with the Global Fund on around COVID?
Thanks, Nadine. And can I just start by saying it's a real honor to be part of such a fantastic panel of women. As has been said, COVID-19 has really drawn into focus the inequities and even vulnerabilities and specific threats for the safety of women and their ability to make decisions about what happens with and to their bodies, and the ability to access essential medications and services for HIV, TB, and malaria. Women for Global Fund and across the movement of women living with HIV, which I also come from, have been bringing visibility to these inequities and inequalities before COVID-19, as Chitra was saying. But now we are seeing communities and women living with HIV and affected by TB and malaria being much more affected by the same issues. Communities of women are really struggling with so many issues right now. And I'm going to mention just a few of these. So there's a lot of discussion around concerns around monitoring of data. And as countries start to look at more electronic tracking mechanisms, how will this then be used and against communities, especially vulnerable communities and key populations beyond COVID-19 control? You know, there's lots of discussions also taking place around access to treatment for HIV, TB, and malaria, as well as testing services for TB, and the fear that, you know, seeing as the gene expert machine can also be used for testing for COVID, that those machines are literally being picked up from testing for TB and being taken. So, you know, they're being pulled away from TB resources, which is problematic given that TB is such a huge global challenge. COVID-19 is also bringing into sharp focus issues around connectivity. It's a huge barrier for communities of activists who are not always online, as many of us are. And this is becoming really important because we can't connect in person anymore. So the digital divide is causing more and more advocates to be left behind, since they can't join these online discussions that they see as only for the privileged few who have access. So we have to continue to advocate for meaningful participation of communities and women so that this does not become the new norm of what doing home from work looks like only for some who have access. I'm going to focus the rest of my comments on two specific areas that Women for Global Fund has been deeply concerned about. And these are, as has been said, issues around violence against women and access to sexual and reproductive health services. So violence has always been an issue. As we know, globally, 1 in 3 women experience some form of violence in their lifetime. But gender-based violence exacerbates women's vulnerability to HIV. Some studies suggest that in high-burden countries of Southern and Eastern Africa, between 25 and 50% of all new HIV acquisitions amongst women are linked to women's experience of intimate partner violence. And this is even more acute for young women. In Southern and Eastern Africa, global reviews show transgender women are at increased vulnerability to HIV, linked to high levels of direct sexual and physical violence. And the trans movement has expressed concern about how they will be treated when they have to disclose their gender if they have to access COVID-19 support. Not to mention the violence against sex workers perpetrated by clients or state actors, including law enforcement agencies. I'm going to sidestep here and just say it's really exciting to see South Africa yesterday endorse its National Strategic Plan on Gender-Based Violence and Femicide, where they actually now have a plan in place to decriminalize sex work by 2024, given its direct links to violence the sex workers experience. There is also increasingly strong evidence for gender-based violence as a consequence of HIV. And this includes research that shows that women living with HIV experience high levels of violence from partners following disclosure of their HIV status. So all of this is now being exacerbated, as has been said, and experienced by women across ages and diversities, having to be at home due to the lockdowns. Another issue is that national legal frameworks provide penalties for citizens who don't adhere to the lockdowns, but they don't highlight any recourse or protections for women who may be abused, even by the police, which includes sexual violence. And this is true in war-torn countries, and all of this will have a knock-on effect on being able to continue to access treatment services around HIV, TB, and malaria, including access to contraceptives. And I'm sure all of you saw, I know the first speaker touched on it, but a couple of weeks ago, The Guardian quoted Mary Stopes International that warned that, you know, these travel restrictions and lockdowns are going to have a devastating effect on women's ability to access contraceptives and other reproductive health services, such as safe abortions, in specifically 37 countries which they work. And they estimate, so this is Mary Stopes International, estimate that an 80% reduction in service delivery for 3 months and minimal services for the remainder of the year will affect 9.5 million people who will miss out on contraceptives. And if things are to return to normal after 3 months of disruption, the figure will drop to 4 million. So all of this has significant implications for the programs that the Global Fund supports, that we advocate to make sure that they're doing the right thing on moving countries towards gender equality. And we really need countries to have right now a gender security awareness and responsiveness. And the Global Fund is recommending that countries reinforce this. So I'll stop there, Nadine.
Yeah, thank you. I was actually just writing down a gender security awareness. I think that's really, really important. And I think we'll have a look and see if we can find some of the links that are probably available already on the Global Fund site and just share them here if we can, if my team would do that. Sophie, I think just to kind of, you said, you know, you've been involved in, and we all know you've been involved in the HIV movement for a very long time as well. And we had Kate Thompson on here a few weeks ago as well. And I just asked her that kind of the same question. It's like, what have we learned from all the years of activism, particularly from powerful, passionate women living with HIV? What have we learned that we can now apply here right now?
So if I look back at the HIV movement, I just, you know, I think our community activism has been the backbone of the AIDS response. Just look at the Global Fund itself. It was born out of community activism and people saying we need a global fund. And no other health movement has moved as quickly as the HIV movement, although COVID might take that over. And that was part of our community response. So and if I compare not COVID and HIV, but if I compare the response to COVID and the response to HIV, a lot of what people living with HIV went through in the early days, you know, huge fear of not knowing where this virus has come from, all the conspiracy theories, the big spacesuits, trying to deal with people living with HIV, the death, the uncertainty, life as we know it never being the same, all of the misinformation. You know, we've been there, and we understand how to be at the table and advocate for what we need. We've become articulate and smart about advocacy and how governments work, and how to track the money. We understand what meaningful engagement means and what that feels like, even online. And as Sazonke said, you know, this is a real opportunity for us to look at all of the issues that COVID seems to have shaken the rug, and all of these issues are being pushed up for us to deal with, and hopefully an opportunity to build a new health system, a new way of being that provides more equity and justice across the world, because what we were living before just wasn't right. I don't know if that helps me.
Sophie, it's so helpful. Thank you. It's really, really inspirational and just so spot on. So thank you for the message for each of us individually, as well as all the organizations and systems that we're a part of. Thank you, really. So brilliant. I'm lastly just going to come over to you, Sarah. It's not an easy position, as you've heard these, you know, these women speak from different contexts. So maybe just in your position, you're kind of in a position of, you know, you're looking at women in global health all the time. That's your core business. What would you suggest in terms of changes that could be made in the context of the COVID response, particularly to ensure the needs of you know, key populations, minority groups, low-income households? How can we make sure that these are, you know, that responses will be integrated and heard? Yeah, over to you, Sarah.
Yeah, thank you so much, Nadine, and thanks to the hosts for today, the Irish Global Health Network, Esther Alliance, and the Women in Global Health Ireland, and congratulations to the Women in Global Health Ireland for your launch. We're really excited to have you as a part of the Women in Global Health Network. But just really briefly, if I may, for those of you who aren't familiar Women in Global Health is a nonprofit founded in 2015 to achieve gender equality in global health leadership. So today, Women in Global Health is a global movement with more than 25,000 supporters across 90 countries. And so what we're really looking at is challenging power and privilege in global health. And so that is our core business, as you mentioned, Nadine. And so, we don't do this by fixing women, but we really do this through institutional change. And so our theory, and this is something that pandemics like this have shown us over and over again, is that when you actually have more women in leadership, then the needs of vulnerable communities are better represented in policy and decision making. And so we actually call this gender transformative leadership. And, just to get to the question that you asked me, Nadine, first, I just want to sort of zoom out and say that, women are actually 70% of the health workforce, but only 25% of global health leadership. So women have this triple burden of, especially if they're working in the healthcare sector, which is, one of the largest sectors that employs women. They have a triple burden of, not only their healthcare job, but the added responsibility of the COVID-19 response and the mental and the social factors that come with that. But also, as was mentioned previously, the responsibility of providing the majority of care to their families and their communities. And so, when children are sick, or when elderly relatives are sick, we see women doing the majority of this unpaid care work. And so, just in terms of, what we can do, Women in Global Health has actually launched 5 asks. So these are our policy actions, for a gender responsive approach in global health security. And number one is what I just mentioned, which is including women in global health security decision-making structures and public discourse. And so, we're really calling for gender parity, so 50% of women in global health security decision-making bodies and expert panels, which we're currently not seeing. In January, only 5 women were actually invited to join the 21-member WHO Emergency Committee on COVID-19. And this is something that we're seeing at the national levels as well. So to provide safe and healthy working conditions for health workers, and this includes adequate PPE, which we're also not seeing, and providing access to menstrual hygiene, protecting workers from harassment. We've actually seen an increase in harassment during the pandemic. And just really the idea that health workers don't want to be sentimentalized or treated as martyrs, but just really want to be able to lead. They want to be listened to, and they want the means to do their job safely, professionally, and with dignity. And so number 3, as I mentioned before, is just recognizing the value of unpaid care work and including it in the formal labor market. So, one really great example of this is that in the U.S., there's a position in the healthcare and home care system called the home health aide, which is actually a paid role in which there's a third party who's able to help with care of elderly relatives and those with special needs. But this is often a position that's uncompensated throughout the world. So ensuring that those types of roles are brought into the formal labor market. And 4 is adopting a gender responsive approach to health security data collection, analysis, and response management. So it's really critical that we collect sex disaggregated data. Really ensuring that we have a full picture of, why healthcare workers are who are majority women are getting infected at higher rates, why men are dying at higher rates. We don't know the answers to this unless we collect gender disaggregated data. and conducting research, specifically on the biological and behavioral risk factors that are different among men and women. For example, pregnancy, breastfeeding, tobacco use, indoor cook stoves, etc. And then the fifth is funding women's movements. We ask that women's movements are funded so that they're able to unleash the capacity to address critical gender issues. Just based on what Sophie was saying, about the HIV movement, we know that right now women's movements are underfunded. But when we empower local community women to lead, then they actually are able to advocate for the rest of these 4 asks that I just mentioned, right? And they are in a position to ensure better outcomes. Just as we think about how we can act now and build better health systems in the future to support health workers, just one thing I always like to say, which our senior policy fellow Ann Keeling always says, is that we know that health systems are operating with one hand tied behind our backs by excluding women in decision making. A strong COVID-19 response and a strong global health security response draws leaders from the entire talent pool. This is a pandemic where we cannot afford to exclude women from the global response. And one of the things that I'm hearing, as I have conversations with our chapters around the world, especially in resource-strained settings, is that we don't have time to focus on gender. We have to deal with this pandemic. That's something that we can focus on later. Right now we're focused on saving lives. And my message to all of you is that, and those who might not be quite as sold, is that we cannot unlink saving lives from gender, right? They're inextricably linked, and I think that that's what's important to remember. So thank you, Nadine.
Wow. Sarah, thank you so much. And, I was going to ask you a question about women leadership, but I see, to me, what's happening here today, I mean, we're just privileged to have such women leadership on this panel today. And it's really inspirational for somebody like myself. I've been involved in advocate of gender and women's rights for many, many years. And just listening to this conversation so intently today just reminds me of why it's so important that we all continue to advocate and continue to do what we can. Thank you, Sarah. I would love to just as we're moving towards the end, to come over to Claire, if I can. And last week, some of you will remember, we focused on mental health and we focused on stigma. And Claire was wonderful. She gave us just such an interesting insight into kind of, just mental health and a few tips in terms of what we can do to support ourselves. So Claire, I wonder if after today you could just give us a little hit in terms of, your perspective on mental health, both for women and for men, and anything practical you can leave us all with as we continue to do what we do.
Certainly, Nadine. I'm really privileged to do this, and thank you to each of the speakers. I feel overwhelmed right now, and I'm just aware of how in your work, at times you do, but you've different ways of coping with it. So I'm just thinking, for the people who are listening to this and for the people you work with, there's a huge amount of stress in the world. I don't separate out mental health from physical health. And I just had an image of somebody walking up a mountain with a bag of rocks. And as they're walking, other people are putting more and more and more rocks in, and they're getting smaller and smaller. They're burdened down with it. So I'd invite each of us to stop, to take off the bag of stuff that we're carrying, and just to have a look at it. Just maybe to write down what is causing us pressure right now, all the stresses right now, and then to look and see what are the ones that we actually can do something about, and which ones are coming from outside. So which are things we cannot control. So right now we cannot actually control COVID-19. There are people working really hard right around the world to control that. We might not be able to control other people's expectations or other people's demands. Looking at what we can control, maybe we can control, actually, I need a break for 2 minutes. I just need to take a breath. I need to walk outside the door. looking at what we can control, and then looking at the internal pressure that we're putting on ourselves. And when we talk about mental health, often people think of depression kind of as number one. And we know that depression is, the number one world health condition, according to the World Health Organization, right across the world. So depression can be a sense of hopelessness about the self, the world, the future. And I think it's really important in managing and coping as well as we can with the pressures of COVID-19 that we allow ourselves to feel overwhelmed and disillusioned, but we don't dive into it. And that we get a balance between somehow there's a sense of hope, and excuse me for the dog barking. So somehow there's a sense of hope, and looking at how we can take support. So for each of us, there is one person who's in our corner. And this person might not actually be alive in this planet at the moment, but even thinking of that person, what that person would say, which one of those stressors we could say, look, will you look after this for me for the moment? I'm really worried about the future. I'm worried about my income. I'm worried about my kids. But will you take care of that and help me just manage with what I need to do right now today?
Thank you, Claire. Thank you. Something for all of us to take home. And we really appreciate that. We appreciate that that we pause. We talk about all the different issues that are external, and then it's really great to have something for each of us to take along. So thank you, Claire. Wonderful. So I just would like to, as one last thing, I'd like one word from each of the panelists to leave us with, literally one word. So if I can come to you, Chitra, what would be your word to leave us with after today?
You're starting with me?
One word.
Come back to me at the end.
Okay.
Now, give me time to think about it, please.
Thanks, Chitra. Sasanki, one word from you. You're muted. Muted.
I'm going to take to imagination and creativity.
Thank you. We got them. Sophie.
I've dropped a comment in the chat box. I mean, for me, it's gender sensitive, gender transformative right now.
Thank you, Sophie. Sarah, how about you?
My one word is equity.
Thank you. Powerful word. Chitra.
Redressing inequalities, taking this chance to do that.
Thank you. We got it. And Claire, from yourself.
Hope.
Thank you. Hope. Wonderful. Thank you everybody for being with us again today, and really inspiring, really touching, really thought-provoking seminar today. Just to remind you all, Women in Global Health, as Sarah said, we're really proud in Ireland to have just launched Women in Global Health Ireland. We can put up a slide on the screen for you there, and you'll see there's an email address, and you're welcome to email anything there. There's a core team established. We're starting to join the quarterly chapter meetings. We've started a stakeholder mapping exercise, and there are plans to continue in the future. So watch this space for Women in Global Health Ireland. So thank you everybody, and back to you, Hala.
Okay, thank you everyone, and thank you to the speakers for this really insightful discussion. And we hope to see you again in the next webinars. So next week the webinar will be about leveraging research and evidence to support humanitarian response to COVID-19, and this will be co-organized with DSA Ireland. So if you have any questions, please send them in advance. And thanks to the attendees for joining us. And the recording will be available later in our newsletter, our website, and also in our YouTube channel, the one in the slides right now. So, and also check our COVID-19 portal for more resources in COVID-19. And we have now also a specific section for gender as well. So thanks again, and see you next week.
Thanks everybody.
Thank you.
Bye.
Bye.
Thank you very much.
Bye.
Bye.
Bye guys.
Have a good weekend. Bye-bye.
Bye. Bye-bye.